We're landing the plane.
Like if you're landing a plane or you're like coming in. Like,
happening right now.
Okay, it says we're live. There we go. There we go. Okay. Hey, everybody. Welcome to the Health Tech Talk Show. We're live, we think, Friday. What do you even, I don't even know the date. The 26th of July. Here we are. Lots of big news happened.
Yikes.
Yeah. Melissa, what do you think?
The world is burning.
No, I think it's fine. I feel like it's cooled off a little bit, but
it's fine.
All right. So, Melissa, introduce our guests, and then we're going to go to the news show. Melissa, introduce our guests. Introduce our guests.
I'm so sorry. I had background noise going on. I'm sorry. We have Cara McCarty Abbott and Dr. Lucienne. Cara is with the Bereavement, Betterleave Bereavement. And Lucienne is the entrepreneur serving as the CEO of Rimidi. I believe I'm saying that properly. And we're very lucky to have them on. I've been going back and forth for quite some time, so I appreciate it. I know some of our guests are jet lagged right now, but we're all here and happy.
Here we are. We also may or may not have a surprise guest from the great federal government. We aren't totally sure that's going to happen, but it might. So, all right. Well, all right. Lisa, it's time for the news show. Are you ready?
Yeah, I'm ready.
You're always ready. Okay. You better be ready because you're the one who sends me all the articles.
I'm ready. I'm always ready because I've already read them and I sent them to you.
I know. Well, that's good because I only read the headlines. So also, is this not the most adorable Health Tech Talk Show cover image designed by Max this week? Oh my gosh. Us with the leaf cutter ants. What? Also, I heard they
kind of fall adjacent outfits today, like on in the graphic here.
I wish I was that trendy. Like I wish I was that trendy. I'm not.
Same.
All right, Lisa, what happened this weekend?
Are you serious that it was this weekend? Like genuinely, I have no idea.
It was like this weekend.
So this week has been like a year or like 2 years or like 4 years. I have no idea. It's actually crazy. So obviously, if it really was a week ago, then I'm sure our loyal viewers who are not living under a rock know that current President Joe Biden is no longer running for the presidency in 2025. And it looks like, as of today, that Vice President Kamala Harris is going to be the nominee. Not officially yet, but like for sure has all the support and all the money and all the enthusiasm and all the memes, which is amazing because I love memes. Big.
Yeah, and that for those of there are like it is a meme-rich environment right now for sure.
Memes.
Yeah, like I said, eventually we're going to do actual real coverage on the election and like what might change if depending on which candidate is elected. But we do know based on all the political pro alerts that we get that her policy is likely to follow that of the Biden administration, or at least that's what it says. But who knows? I'm just kind of excited that there's someone who might decide to protect our lady parts, but we will see what happens. Things change all the time.
You know what? I will keep saying that that we if this is really just a week ago that this all happened, we have no idea what's happening in a month or two. No clue.
I know.
We'll see.
I know. Also, the world melted down. This was actually Friday. We didn't really talk about this too much on the internet last week. But this burnt down like basically all the airlines, which I fly on a lot. So the CrowdStrike thing, it was obviously not great. A lot of hospitals are still recovering from things they had to reschedule and, just shit that didn't work. So pretty bad. I guess it shows that we're like pretty dependent on
really
technology.
Embarrassing. Really embarrassing because first of all, like the guy who runs this company, like also was like part of McAfee when they had a huge outage like a couple of decades ago as well. So like his personal track record is like not great, which is cool. I definitely think that you should keep hiring people who make huge mistakes that melt down the entire global internet. But what do I know about that kind of stuff? So
well, you know what, Lisa, people fail up like super well.
People fail up. Look at me, super successful. Failing.
Former practice
super successful. I don't know if I can say that, but whatever. In a very small, very tiny little small, as Kat would say, a whale in a glass of water.
Yeah, sometimes I'm a whale in a thimble of water. But anyway, yeah, this was bad. We actually have a super special guest coming on next week to talk to us about how this relates to healthcare and some analogs between some of the incredible systems that we have that keep healthcare afloat, kind of like, the United Healthcare, Change Healthcare debacle, and like basically how that like ruined America for, and some practices are still suffering from that. So we're going to have a guest to talk about that. So we'll see what's what, and what we might actually pretend to be real journalists for like 20 seconds. We will see what happens. This was fun. This is a continuation of the epic particle care quality debate. I actually think we should, much like Clay Ferris told us to stop calling the Change Healthcare hack the Change Healthcare hack and instead call it what it is, the United Healthcare disaster. I feel like we should actually start calling this the care quality disaster.
Well, that's a little more specific, but I can't disagree with you there. Very interesting article here. I think people were a little confused because the full article, Politico Pro, is behind a serious paywall, like a no joke paywall, like a really expensive paywall. So people don't always get the full context, but they do, to be fair, incredible work. They have, great writing, great insights. And so if you only saw the free version of this, I think you missed the kernel in the story, which was that the Politico team, for whatever reason, had new information about the effect of the care quality issue on the VA and how the VA were reporting it as a breach, which I think was newly reported information. Like, I'm not a real journalist, as we all know, but I think that was a new bit of information that you might not have seen if you only saw like the free preview of this.
Yeah, that was, I had not seen that before, that the VA was like on it and notifying patients. And it was a few hundred, it sounds like, maybe 500 or so.
And like, no matter who you are, like, are you mad at like our nation's veterans who are like just trying to receive basic care and they're getting their data like tossed all over the internet? I'll remind everyone that the point here is about Integratort, which is not a company you should be defending. Integratort's own ads say, because sometimes patients lie. That is their whole like argument. And so for someone to be like, they're just really nice people who have hired some nurses and they're trying to get information for patients. It's like, no, it says because sometimes patients lie. This is not a company that we should be defending in any way, shape, or form. They are bad.
Yeah, and their claim is that clinicians with an NPI pulled the data, and they pulled it to confirm a diagnosis. And our good friend Genevieve Morris, who I think she's still policy lead at Change Healthcare. I actually don't recall if that's still true, but she posted on, I think it was, of course, friend of the show, Brendan Keeler's post about this, saying like diagnosis of treatment is not treatment, or diagnosis confirmation is not treatment. So again, like here we are.
Just if you look at like the words, that's not treatment.
Yeah, so not great. So as like continues, it also seems like I don't understand how this hasn't been settled yet. Like, how is this still in dispute? This article confirmed that it was still in dispute, which I think is like super dumb.
Lawyers. The answer is lawyers, Kat.
Well, that's the thing. I am just, I have little lady brain over here, so I probably don't know how that works. Anyway, so we don't know when our special guest is showing up, but we're going to go through this anyway with my pixelated thing from my screen grab. So like we learned yesterday that ONC is now a big deal.
Well, I mean, it's still a kind of nerdy little deal for policy nerds, but they are now the Assistant Secretary for Technology Policy and ONC. They couldn't get rid of the ONC fully, but they are now, and they have moved up to the HHS level. They are still, in nerd terms, a staff division versus a special operating division. But that's anybody who's like a policy or technical advisory to the HHS secretary. And our friend, maybe future guest of the show, Mickey Tripathi, is now officially the Assistant Secretary for Technology Policy and the National Coordinator and the Acting Chief AI Officer. He has multiple titles. Congratulations.
That guy has as many titles as we do.
He's got a lot of titles. He's good. And also, I think we should just say it right now. Why not? We also learned that other friend of the show and in real life, Steve Posnack, is now the principal deputy. Yeah, there you go. Principal Deputy Assistant Secretary for Technology Policy, which I think we should just say here, this is a title that was promised to Kat. And I know that like government officials can't promise, like probably everyone's going to prison for that, but like, I will just say somebody told Kat that she might be able to have this job, and now Steve has gone in and taken it from her. just
Pays to
ripped
eat
it
it
out
for
of her
me.
hands.
Oh my God. Yeah, I've
Ripped
been
it out of her
offered
hands.
this job for like
Amazing.
probably the past 10 years over drinks. So it's
Yeah. I mean, I don't know
it's
if we're a
probably not.
serious person.
I-
I'm just saying,
listen,
Steve
it's never
got the
been in
job.
writing, Lisa. Never been in writing. So it's fine. Steve,
Speaking of lawyers.
congratulations on your actually. So this is what we have to ask our friend of the show if he actually shows up. Our government authorized friend who may or may not be authorized to tell us anything about this. But like, did Steve get a promotion?
I don't think it's a promotion per se. I mean, Steve has been the deputy national coordinator for quite some time. There's all kinds of weirdness about like when and how they apply the like principal deputy, other deputy. Sometimes principal deputy is like a political appointment, but I don't think that's the case for Steve. He's been a career employee, hi Steve, of ONC for a long time. And so I don't think that's the case here, but these are just all like the little like title things they can do and change.
I don't know. The more words in your title, the better. So Steve, we salute you. Congratulations on your promotion, potentially. Regardless, super psyched about your new big long title. That's great. Okay, so so our top secret guest is probably Stefan. He's going to come on and talk about our the new jobs that are open as a part of this this thing. So we're going to come back to this slide. But as you all heard last week, HHS is now, the postings are open for Chief Technology Officer, Chief Artificial Intelligence Officer, and Chief Data Officer. Now, just like I said, the longer the title, the better. So all of you should be applying for the longest title here, which is Chief Artificial Intelligence Officer. It's probably going to do a paragraph return. It's so long. So, looking forward to what happens there. And Mickey is the acting CAIO right now.
And it's because the reason why he has to be the acting is because basically there was an executive order around trustworthy and safe AI from President Biden. And they were like, you got to name a chief AI officer ASAP. And so they were like, Mickey, you're the chief AI officer. Can we get a real one?
Here we are. Also, Gloria Vanderham says, congratulations, Steve Posnack. Also, so that's great. We're just bringing in the love here. Okay. All right. So Lisa, you've told me that AI has peaked. It is dead.
Yeah. I mean, maybe controversial perspective here, everyone, but like the signs are all, we have at least gotten through this initial massive bubble, or this current bubble we're in is really about to pop or has already popped. In particular, OpenAI becoming more and more of a fake company, has no more money, running out of money. All the big tech companies, big surprise, they've built this huge moat for themselves, and they also have comparable AI tools now. They've had enough time to catch up, and they're like, guess what? Our stuff is good. We're just going to build it in. We're going to use it to, continue to create a competitive advantage. And we have more money than you. So we have more money, we have more compute than you. So bye. So basically, Facebook, Meta, Google, Microsoft are just going to sit there as they have before, Amazon, and just build their moats even higher. And companies like this are probably going to go away, and it's going to become more and more part of like the enterprise stack and call it a day. So sorry, everyone.
Yeah,
it was over.
It is kind of sad though, like the fast follower phenomenon, right? Like some organization. This is why, like, when a company tells me they open it, this is kind of a big deal in general, like the things that this organization has been able to do. But like whenever a company's like, we are first to market, we are incredible, and then I'm like, wow, fast follower, like second mouse gets the cheese, right. WTF, yeah. So that certainly is a thing. Or like, we stand on the shoulders of giants, when really what you say is we're crushing our competition. Like, that's kind of how I feel here. So I don't know. Maybe they'll raise all this money. I don't know. But yep, as usual, we're over here just saying AI is not as cool as you all think it is. I don't know. This is funny. Talk about this one. This is our friend of the show and former guest, Nikhil.
Friend of the show, Nikhil. So we talked before on the show about the sort of retail healthcare flameouts across Walgreens and CVS and Walmart and others, and what that's actually looking like. But basically, Walmart has decided to shut down their clinics. And Nikhil is talking here about the various steps that happened in this process. Walmart was going to merge with Humana. They said no. They built their own clinics. Walmart's shutting down the clinics. Now they're selling the clinics based to Humana. So I think Humana is the winner here. Congrats to Humana's team, who are pretty sharp for a medium-sized, massive insurance company.
Yeah. Interested in how this plays out. Like if they're able to like make it useful.
Yeah. Fingers crossed.
I don't know. Someone's going to eventually figure it out.
Yep.
Maybe. Or we can just keep trying, and we will keep having the same headline over and over and over. And we might even have the headlines in screenshot form from Nikhil's Twitter account or X account.
We
whatever.
might.
So
It's pretty funny.
yeah.
Worth a follow.
Yep. Oh yeah, this is like our promo to friend of the show, and we are actually her super fans. Alia Suleiman, she's like a real lawyer. We were actually talking to our friends Bill and Steve from Point Click Care about Alia, and I was like, oh, she's like my favorite lawyer. They're also lawyers, so I had to be like, oh no, guys, like I mean, I love you too. And they were like, no, they were like, no, Kat, like Alia's like a real lawyer.
Aw, she's great.
So
yeah,
so she has been I mean, Lisa, you've seen these, she's been publishing, I think she's doing a series of 5 HTI 2 highlights. So they're really good. In fact, I just did a podcast and I read them before I went on the podcast so that if people
Really
ask me, I would
helpful.
sound smart. Yeah.
If you want to sound smart, definitely follow Alia, and also check out her highlights. She's put them in really helpful slide form. It's very good, and it's going to be. Obviously she's only on like day 3 now, so there's still a couple more days, but definitely read them, and you will get a good sense of what's at stake here with HTI2. Reminder: HTI2, like more than 1,000 pages of new regulatory text that ONC just put out there right before doing their rebrand to ASTP ONC. So, keep an eye on that. Lots of interesting stuff. Please put in your comments. Like I think Alia and also Brendan Keeler, another obvious friend of the show on last week, has also done some great summaries talking about what's at stake and where we need comments and feedback from the public. So just really encourage you to take a look at those if you care about the space at all. It is important whether you're in health tech or interoperability or whatever else, like lots of potential effects here.
Yeah, even if you like something, like a lot of us write in comment letters and we're like, that's bullshit.
I like this.
We spend a lot of time saying like, that's dumb. You should never do that. Like you're going to rot in hell for even thinking that's a possibility. However, it's really important if you like something to tell them too, because if some other asshole who may or may not be me doesn't like the thing and writes more letters than you, that's not great. So write letters, even if you like the thing, please. And thank you.
I agree.
All right. And then what else we got here? Oh, Lisa, this is just where we're going, where we're doing the live show over the next few months. These organizations were potentially not sober when they invited us to the live show with their stuff. So
there are no take backs, so they can't take it back.
No take backs. They said they could do it. They said we could do it. So
man. We're going.
We are.
We're going.
We're going to the Epic user group meeting. We're going to like interview some luminaries, TBD on who, because we haven't really thought about it yet. And we may or may not buy a new camera by then that actually works. So look forward to that, loyal followers. Health Data Palooza. We're also potentially throwing an interesting person dinner one of the nights of this amazing conference, which we are going to make probably the coolest thing on the planet. Lisa's conference. Lisa, are we doing a live show at your conference? You actually haven't told me.
Yeah, absolutely. So last week I complained loudly that Kat had not included something about the Civitas conference. So I'm doing it here. We are totally doing a live show. It's going to be amazing. It's in Detroit, mid-October, lots of cool stuff. Please definitely come. It is going to be very cool. And who previously mentioned, Mickey Tripathi will be on a panel speaking, the head of Medicare, Dr. Meena Seshamani, the head of the Indian Health Services, Rosalind So, Michigan Lieutenant Governor is going to be there, Garland Gilchrist. Like we got all kinds of cool stuff happening. Kat's going to be there for sure. She's definitely planning on coming. I can tell by her face.
Melissa's coming. Melissa's coming.
It's going to be great. Melissa's coming. It's going to be amazing. Show up.
Yep. Also, God bless InterSystems.
Yeah, they're great partners, great friends, awesome people.
Everybody loves those guys. All right, we're going to health. Everybody knows that. It's going to be great. And then we're going to Poland, this is just my headshot again, Lisa. I'm sorry, we're going to get one with you, but like right now it's just me laughing and looking adorable and delightful. So, all right, that's it for the news show. Okay.
Wait, I have one more news thing that I saw that I don't think made it into our.
Hold on, Lisa. We also have music.
Oh,
it's not playing. I don't know how to do it. I don't know. This new platform has music.
That's a very odd transition. Great. Good job. There was a really interesting article, like an expose in Bloomberg Business Week about the current state of nurse practitioner education in America, which I think is going to be a very, like, just a flag for the future. We can bring on some friends from AAFP in the future and talk about it more, but like, especially as it relates to health tech, and also from Nurses Association as well. As it relates to health tech, like, it's a really important one because a lot of health tech companies definitely rely on nurse practitioners for clinical oversight, clinical delivery. So I'm just kind of putting a flag on that for the entire community, just to say, like, there's some stuff up there. We'll put a link to it. It is a well-researched article. More to come.
Awesome. Okay, great. Love it. That must have been in one of our disappearing chats because I don't know where that link is.
Totally. It just fixed my lighting. Sorry, everyone. You can see me now. Yay.
I don't know. Here you are. Okay. All right. So our first guest is Dr. Lucienne Ide, who does have jet lag. And so she has selected the first slot of the show today. She's the CEO of Rimidi, and she is joining us, beaming in from Atlanta, which I would love to say is near me, but like Atlanta, like nothing's near anyone. So I actually don't think we're probably like hours apart. But welcome.
Thank you. Yeah, we might be 20 minutes apart or 2 hours apart. It just depends.
That's right.
Yeah. God bless Atlanta. And I think we were introduced originally by our dear friend Kirk Barnes.
Yeah.
Maybe. Yeah. That guy's great. So, I looked at your website for approximately 2.7 minutes and saw that it looks like what Rimidi does is works with devices, gets all the data, and then flips it over to the EHR. Is this true? Is this not true?
I would say that is true, sort of tactically. Maybe, what we are focused on doing, though, is helping practices manage chronic conditions in their patient population. Yeah.
What do you think of all these Peterson Health Institute studies that everyone says are bullshit?
I think they're bullshit. Yeah. I mean, at least the one with diabetes.
Nice.
I mean,
love it.
That up.
Love a strong opinion, and we love it. Say more.
Tell us more.
I've been doing this for a long time. So I'm a provider by background, physician, left practice. About 12 years ago, started a tech company to try to make it easier to have data to make data-driven, evidence-based decisions about patients. So like that is our DNA. Wouldn't it be nice if when I was seeing a patient, I had the data I need and the evidence I need and the insights I need to make the right decision? Because I think that's what all of us as patients assume is happening. And unfortunately, that is not at all what is always happening when you see a doctor. So I've spent the better part of 10 plus years working on diabetes care, which was their first big report that was really controversial that came out. What I agree with, I think they highlight some of the places where folks aren't doing these programs using tech for the right reasons, right? Like all of the downside to new reimbursement models for remotely monitoring patients is you're going to have people who are chasing reimbursement in dollars and aren't instead using reimbursement as a way to support a program to deliver the right kind of care to patients. So that's my positive takeaway, is that they highlight, yeah, people are doing this well and people aren't doing this well, and we should focus on doing it well.
Yeah. All right.
Yeah.
I'm just like pausing to see if you say anything else. Okay. Fantastic. Love it. Okay. So I saw you actually speak at some, I actually can't remember what it was, but some event in the fall in Atlanta, and you were speaking on AI. So you're like a medical doctor, you're a PhD, like, tell us, like, what the heck? How'd you even get here?
Yeah. Well, and also, do you have a reaction to my provocative statement that the bubble has burst, we have peaked, at least for this round? You can say no, you don't have to agree with me. I'm probably wrong.
Right. Yeah. I mean, I think it's a tough dynamic, right? That fast follower taking on the companies with enormous war chests and moats. So I, empathize with the disruptor, OpenAI, on sort of their position in that. I do think a lot of, in the world in which I live, talking to providers and health systems about the use of technology in patient care, the fatigue is real. Right. I mean, if I get on the call and after 30 minutes, I still haven't mentioned AI, I often get the comment of like, thank you so much for not leading this conversation with AI. If one more company gets on and tells me what AI is going to do for healthcare, like I might just hang up on them. So, yeah, Yeah. Overhyped, there's
Cringe.
really good ways that technology will drive better patient outcomes using AI, but not today at scale.
Not today.
Yeah.
Love it.
Just like the wrong level like of abstraction. Like, why would you start with saying with AI? It's like, no, there's a problem to solve. There's a health
Right.
outcome problem to solve. There's a care delivery problem to solve. Like, I don't care which programming language you use or like specifically which algorithm or model you use for that. Like, I care about the outcome. Most people do. Like, no, unless you're specifically talking to a group of like ML engineers, like no one cares.
I 100% agree. Yeah. One of the best things one of our investors said to me a long time ago, we were sitting in their big headquarters building, and he was like, I don't want to buy an HVAC unit. I want to buy climate control. Like, that's what people want.
Totally.
They want an outcome,
like, whatever.
right? Yeah.
I want it to be cooler here, please.
Exactly. And I feel like AI is the same. Like, I don't want to buy an AI-enabled such and such technology. I just want to buy an outcome or buy a service.
Yeah. Love it. Okay. Yeah. But so how did you end up being like this person who speaks about AI and everything and like a founder and also a doctor? Like what happened? What happened to you?
I don't know. I keep trying to find a job where I can make a difference, I guess. So I started my career in DC with the government, working in intelligence, thinking I would like find a problem there that I could, contribute to. And then went to work in venture capital and decided that was less full of, altruistic problem solvers like myself. And decided to become a doctor. Yeah. That would be the intersection of my love for science. I was a physicist for the government. That I would bring my love of science to people and become an academic clinician. So I did the whole MD PhD thing and was going to run a lab and do clinical care and teach. And I did residency in OBGYN, and it was right when all the EHRs were rolled out. And so I went through this it was like Groundhog Day, right? Every hospital I'd show up at, they're like, we are going live with something called an electronic health record. I was like, oh God, I've just done this 5 times. And so I was fascinated by the disconnect there, right? Of the promise of digitizing data, right? Clearly was going to make this tremendous impact on patient care and clinical workflows and efficiencies and everything, right? Except that none of that really happened because most of these systems were architected for billing capture, which also needs to happen, super important. People need to get paid. But I was just really interested of why didn't people first ask end users who were using these systems in patient care what they wanted and what their workflow looked like and, how to make that easier to make the right decision about a patient. So decided to leave clinical practice and go work on that.
That's really funny. I was just reminding me of a conversation I was just having today with a new friend, James Howgate from Guidehouse, who was also for a long time in Georgia Public Health and at CDC. And we were talking about, the evolution of the industry, what you were saying, the meaningful use incentives and getting people on. And he was like, I would just go out there and they would say, son, I don't even have a computer. Like the rural, like, what are you talking about with this money? Like, I don't even have a computer, just the vibes.
I am a computer.
Yeah,
exactly.
Yeah, it was like a lot less efficient. It was a lot less efficient for a lot of doctors, right? And I remember in one epic training at an unnamed hospital, one of the docs raised their hand and they were like, wait a minute, I'm now going to do all the data entry, that usually like the floor clerks and other people did into systems. And the poor epic trainer was just like, yes, you are.
And they were like, potatoes, tomatoes, bananas, like we're throwing
Love
it.
Like,
get out, leave. Yeah.
Oh my God. Oh my gosh. So, okay. So, I like you said, you're selling climate control, not an HVAC unit. But talking about RPM, right? It looks like a lot of some of the, at least more tactical components of chronic care management, chronic disease management it does include RPM for you. So former friend of the show or former guest on the show, he's not a former friend, he's a real friend, Clay Ferris, who's, I think he's the CEO of, mostly Medicaid, right? Consulting firm, whatever. He came on, he was also drinking with us when he did this. And he said, RPM is just for people who didn't get to the telehealth trend first, or he said something like that. Like, what do you think about that? Is that like true?
RPM is for people who didn't get to telehealth first. I don't know what that means, but
Good pivot. Good pivot.
Well, somebody was drinking, so I think that
Yeah,
probably answers your question.
But here's
Yeah, he
what
was
I-
like, remote patient monitoring companies were just too late for the telehealth trend.
Yeah,
is what he
here's-
was saying.
So like, I started the company in 2012, right? Way before there was reimbursement for RPM. So we were enabling remote monitoring of patients, not in the term of art today that we all refer to as RPM, because there's a CPT code for that. Because I didn't know how else one would manage a chronic condition if you didn't have more data than twice a year when you saw the patient. And, this is like early 2010s. The devices out there kind of sucked, right? We worked with all of the leaders, right? Telcare was the first cellular enabled glucometer that got approved. Like we tried everything that anybody could get approved by the FDA. But only kind of accountable care organizations, Medicare Advantage groups could justify doing this kind of work because they were the only ones that had the right financial incentives to be able to invest in resources to drive better outcomes. Then this thing called RPM explodes, right? Because reimbursement is introduced, which I think is awesome because it opened up the market to a broader set of providers. But I think what's been hard to separate is sort of the activity of, and the goal of better managing chronic health conditions from the specific activities that are billable under the set of CPT codes. And those two things have gotten kind of melded in our vernacular. And I think I try to keep them separate because I'll be the first one to say, I don't think CMS intends to pay these codes forever. And, I tell
it's like a
clinics,
bridge,
I'm
like a transition kind of thing. Yeah, totally.
Yeah.
I agree.
They're training wheels.
Yeah.
They're training wheels. They're giving you training wheels. Yeah.
Exactly. If you look at their goals around accountable care, which I have lots of questions about and I could poke holes in all day, but truly the idea, which nobody's going to fight on this one. They're trying to get everyone into an accountable care relationship by 2030. And in that accountable care relationship, you are going to have one population payment or a couple population payments that are going to be for things, including some kind of, you can call it RPM, you can call it asynchronous telehealth, you can call it whatever you want. But the idea is that you need to have this ability to have devices, data coming from the patient who's dealing with a or multiple chronic conditions to allow people to treat them and to allow them to be part of that accountable, care model or whatever it is. So the reimbursement it's important, like you said, but it's like secondary to what we're trying to actually do to improve care with that remote monitoring, with that, something that someone has in their home on them all the time because they're dealing with a or multiple chronic conditions.
Yeah, 100%. Yeah. I mean, so, I'll tell docs and health systems all the time, if like, you have a moment in time here where CMS is like giving you some training wheels to learn how to ride a bike and they're going to take them away. So either you can learn now while there are funds to support it, or you wait till 2030 and fall off that bike a bunch of times and it's going to be painful.
Interesting.
Do you think that's actually going to work? Or do you think people are like, I feel like always everyone just falls off the bike. Like there's no like, there's no off ramping. It's just like,
yeah. I mean, so many thoughts on the whole ACO thing, right? And sort of version 1 and 2, and why didn't it work the first time? I think it was a bridge too far, right? For so many groups that they couldn't just like overnight be like, hey, I want to be one of those ACO things, but there's no pot of money that comes with making that decision that then pays for all the infrastructure you need to do that well. So that's my hope, is that the government has learned from that experience of like, we need to get everybody aligned between more cost-effective care, but we have to onboard them to that in a way that they can be successful. And so I don't know how we offboard people from, CPT codes for RPM and onboard them to population health management in a graceful way that they don't fall off the bike, but I'm an optimist. So I think we'll do it.
Well, that's a real question for the next administration, the next CMS administrator. I obviously, my biases are clear. I am very deeply hopeful that there is a serious move when it comes to Medicare and wherever appropriate Medicaid towards truly accountable two-sided risk in the near future. And I also believe, obviously, very clearly that data and technology is a critical part of that. But it's been a challenge now for multiple years to get people into CMS and to HHS who have that experience, who understand those systems, understand those tools, who understand that in a real way, to actually be in leadership roles and feel empowered enough to make big changes, right? Can't keep going like it is. You can't just, again, we were complaining last week about, the every single year changing the payment rules, updating the codes in a way that is like a huge amount of work for organizations to encompass, like these things aren't working together, and we need more actual leadership and the ability to say, like, we're doing this now, or we're not doing this anymore. And that's a leadership thing, from the government, from the president to HHS secretary to the agency leaders. Like, come on, y'all, we can do it. Who's with me? She's all,
What is your least favorite piece of policy? Healthcare policy.
My least favorite piece of healthcare policy. Maybe I'll pivot on that because I'm jet lagged and not totally thinking of my least favorite, to say the most confusing piece that gives kind of a headache is HIPAA, like the lack of understanding of HIPAA. And the excuses, like people use HIPAA as a cover for not doing so many things that it has nothing to do with. So yeah, my favorite story is I was once at the hairdresser and asking them about why I couldn't book an appointment in their app with a particular stylist. And they told me it would be a HIPAA violation.
Stop it. You're like, do you know what you're talking about?
That's amazing.
I was like, you just went to the wrong person. I actually do know something about this, and booking an appointment to get my hair blown out has nothing to do with HIPAA. But
you can just say they're on
totally
leave. You can say they're on leave, and that's not a HIPAA if that's really what, that's ridiculous. Come on.
It's amazing.
It's amazing. Yeah, so
I agree.
Yeah. Yeah. I mean, it's just, it's become a joke of, when we're talking, and maybe it's gotten a little better in the last few years, right? But it's always like, oh, we can't do that because of HIPAA. And I'm like, what aspect of HIPAA? Tell me more.
Yeah. I'd say like, I always joke about this. Like, I'd say once a week, someone accuses me of violating HIPAA for like doing very not illegal things. Yeah, hey, Zach Finn, you're correct. HIPAA citizens arrest. Yeah, no, but it's always like something, or it's like we actually have a team member who was trying so hard to get her medical records, and they weren't really, HIPAA with 2 P's, also a strong one. But yeah, trying so hard to get her own medical records, and they were like, no, releasing them to you would be a HIPAA violation. And I was like, it's like mind-boggling. But yeah, I agree. Somehow that's still one that boggles the rest of us. Okay, so we bring people on these shows and like we never really know what they're gonna say. So like, what did you want to come on and talk to us about?
Amazing.
Yeah. What did you want to say?
This has been great. I have like a whole reading list for this weekend, and you've pretty much summarized my life for the past week in the news intro. So, I don't know if you have anything else to say. I mean, I had a delayed flight this week.
Where'd you come from that you're jet lagged?
I was in Sweden, for a while, escaping the heat here in Georgia. But then I ended up in JFK on Wednesday night, right? And my crew didn't show up for Delta because of the whole CrowdStrike thing. And, and that was amazing. So.
Yeah. Not great. Okay. Well, so summarize our learnings from this conversation. I'm just going to put words in your mouth. AI is kind of bullshit. It's the HVAC unit. Sounds great. All that digital therapeutics reporting bullshit is bullshit. Sweden is great. What else, Lisa? What else did I miss here?
Yeah. I mean, I think that, this work around RPM greatly precedes whatever couple eras of telehealth we just went through. And it's all about, getting care to people in the home and being part of improving outcomes in an accountable care future.
Yeah.
That's my
I mean, in Walmart, which I have a lot of opinions on all of that. So I'm going to go read that thread. But one thing I feel really passionate about in our work is, helping existing healthcare entities transition to the future of healthcare delivery, right? Adopt these technologies, be successful in accountable care type models. They have to use technology because there are no people to throw at the problem, right? I mean, that's been the historical approach. Like, better manage chronic conditions, throw some nurses at that and you can achieve better outcomes. But you know what? I'm sorry, there are no nurses, right? And there are actually not enough doctors, and sounds like there won't be enough nurse practitioners. I don't know. So I have found the Walmart one fascinating because everybody wants to throw some novel outsider care delivery model at it of like, oh, Microsoft, Walmart, somebody's going to swoop in and fix this for us. And I just don't believe it. I think we have to fix a big part of it from the inside. So there you go. That was my last topic I wanted to talk about.
That was good. Well done.
Very cool.
Well done. All right. Well, our top secret guest did show up. Stefan, is your camera even on? Like, what's going to happen here? All right, Lucienne. Thank you for joining us. Thank you for coming to the Clown Show. And we're going to real quickly switch over to Stefan so he can tell us about the great changes at our federal government. And then we will move over to Cara, who is a legitimate and real scheduled guest. So thank you, Lucienne. We appreciate it.
Thanks, Lucienne.
All right, Stefan, what happened? Here, I'll show you. Look, we already talked about your logo change, which is pixelated because this is a screen grab. But congratulations on becoming something different.
Yeah, my background's already out of date. I already got and actually I'm wearing this retro ONC t-shirt that's, probably worth millions of dollars on the internet right now because,
oh my God, you should auction it off for a good cause.
I should. In fact, I think I made a promise Lisa at one point I was going to order one of these for her. I'll see if I can still do that before we switch over to the new swag.
You better. You better.
Exciting times.
Okay, you guys. So for those of you who don't know Stefan, everybody knows Stefan. In fact, that's the number one thing a new person will tell me on the internet when they have like a Zoom coffee date with me. They're like, "Oh yeah, do you know this guy Stefan Kanye?" And I'm like, "Yeah, everybody's."
Unfortunately, you do, right?
Yeah, it's like totally a problem. But Stefan is here to tell us about this like amazing rebrand. But mostly, he wants to tell us about these jobs. Is that right, Stefan?
I love the screenshots you got going here. This is
you like it?
My life a lot easier.
I pulled that off the LinkedIn.
I was trying to figure out if I was going to have to do that. You guys are so professional.
Yeah. Well, yeah, we've upgraded a little bit over here. You're welcome. But so I usually introduce you as the head of innovation at HHS, but I have actually captured your real title here. So introduce yourself real quick and tell us about these jobs and like everything that's happening.
In 2 minutes.
No, this has been a lot of work that's been happening behind the scenes for months and months. We've got an amazing team at ONC and across, HHS in general with the Secretary's office that was instrumental in making this all happen. Specifically, Deputy Secretary Andrea Palm and Sarah Esty as well, who works under Andrea. The two of them really drove all of this and worked closely with Mickey. And essentially what we announced yesterday was a huge reorganization across HHS. ONC, as it was known before, is now been elevated to an assistant secretary level status. So that gives us a little bit more breadth and influence across the department. And in that move, it also pulled in some of the other functions around data and interoperability and AI that previously resided under OCIO, under the Assistant Secretary for Administration. So those got moved underneath this new office of the Assistant Secretary for Technology Policy. And we still have to keep the ONC on the end there for a while due to some statutory
for legal reasons.
Yeah, the things like, for instance, the high tech reports to ONC, and if ONC just goes away, then there's no high tech reporting to anything, right? So we've got to make sure we still kind of keep these things in place until all that can get resolved on the back end. So Mickey does have the title now of Assistant Secretary for Technology Policy. That's his role officially. And he also is the National Coordinator for Health IT still. And he still also has the third role that was announced not that long ago of being that acting Chief AI Officer per the Biden administrative order that came out, or executive order that came out on AI, where every agency had to name one. And a lot of people were confused on what that meant. But, a big piece of that is we couldn't share quite at the time that this reorganization was happening, and AI, the Office of the Chief AI Officer, was being pulled in underneath this new office that we're leading. And so we'll be filling that role. That's one of the 3 postings that you showed. The CTO is going to be a new office within what was formerly known as ONC and now known as ASTP. So the CTO will be reporting to Steve Posnack. And then the Office of the Chief AI Officer, the Office of the Chief Data Officer.
And also, It's reporting to Cat is what you mean.
The same thing. Who doesn't? Who doesn't?
Right.
Yeah,
that's what I'm talking about.
And then we have another program that'll be built underneath there that'll all be new branch essentially of our agency, and exciting. So once we fill that position, the job's officially opened up. I know we kind of trickled it out last week on the show. Thank you for emphasizing our LinkedIn posts on those 3 opportunities. But now that this reorg has happened, the job postings are on USA Jobs. Anybody can apply starting today. And also, they're only open for 2 weeks. So anybody who is interested, get on USA Jobs, create your profile, upload your resume. If you have questions about ways of filling out applications to work in the federal government, I'm sure Lisa can guide you, given her past experience.
Lots of detail, lots of words, add a lot of extra words, all the words.
Right. There's a bit of a science that if they say they're looking for this, make sure you reference that in your resume somewhere so the AI can tag it all, right? But yeah, it's gonna be. We've got an amazing response so far. I can't tell you how many people have reached out with interest. We want to continue to make sure we get a really wide net cast, very large pool. These are career SES positions. So that's something else that's really exciting. These are ones that are career professionals, SES positions. So, hopefully these are not tied to any kind of political position, right? And hopefully it gives them some staying power through changes in administration and things like that. So we're very excited about it, and hopefully we'll make it a little easier.
The previous CTOs of HHS were Todd Park and Susanna Fox.
Extremely exciting. Yeah, they're very excited about it. I actually encouraged on my post for them to kind of share their thoughts about what it was like being in those roles, and have gotten a pretty good response from them about their excitement for it and glad that it's coming back, and also feeling. I think if you talk to some of them, you'd hear about some of their frustrations when they were CTO about how it didn't have dedicated funding lines and how it was not really well kind of established and coordinated at times across the agency.
Mm-hmm.
They're kind of borrowing and stealing for funding for initiatives and things like that because it was all kind of early on, it was getting built up. And this gives it a more permanent structure within this new Assistant Secretary for Technology Policy framework. So again, we're very excited about it. We really want to make sure we get as many people to apply as possible. And then, we'll spend the next couple of months sifting through those resumes and hopefully hiring the best and the brightest to take over into this next chapter.
2 weeks, people. You have 2 weeks to apply.
That's it. Yeah.
This phenomenal opportunity. So, Stefan, big question is, does the ASTP ONC now have more money?
Technically, yes. Because there's funding. I mean, we're not talking about a lot of money, but there's the existing budget lines that came with the Office of the Chief AI Officer, the CDO, et cetera. Those have been moved over from OCIO underneath us. And then there's going to be a little extra added to that in the short term. We also are taking advantage of volunteers. So we have people on detail assignments from other agencies that are coming in to help kind of support getting all that work up and running. And who knows in the future, obviously we depend on working with OMB and the Congress on any future funding levels post October 1st. So that'll be an ongoing, process. Like
give them more money. Give them more money. If you're listening to me, give them more money.
More money would be great in general.
Actually, a good friend of the show, Brendan Keeler, I think he actually posted something that we saw and thought it was pretty funny. He was saying that HTI2 came out and said, we're doing everything in with all these different policy levers. And then he said, basically what this reorg means is we need more levers in validating that. So appreciate that comment from Brendan as well. We tell him we did see that and it is funny, but yeah.
Good job, Brendan. Good job. Internet luminary. Okay. All right. Well, so obviously spam Stefan if you have any questions about those opportunities. Maybe Brendan will become the new CTO of HHS. We're not sure. It's very exciting.
It's interesting. The one last thing I'll leave too is if you are interested in any of those 3 positions, there's a webinar on August 1st. So next week on Thursday, there's a webinar where you'll hear from Mickey and Steve and Lisa Lewis, the new Assistant Secretary, Principal Deputy Assistant Secretary, and Lisa Lewis is our other Assistant Secretary for Technology Policy, talking about these 3 new positions in the reorg. That'll be on August 1st. And I can drop a link to. Is there a chat here? I can drop a link.
We are going to post it. We will post it.
Awesome.
Yeah, just post it in there or not, and we'll put it there tomorrow. It'll be fine. Yeah.
People have questions. Go to that webinar because that's going to be the source of truth.
Awesome. All right, Stefan, thanks for joining us and telling us all the real deal instead of us sitting here guessing. We appreciate it. You're the best.
No worries.
Love the t-shirt. Please do send one to
Yeah.
Lisa. And I think Alia here is wondering when you will have swag.
Well, you know, I got to work that out. I know our team is working on it already. They did say that. So they got
Top priority.
This is only available to ONC staff right now. And so maybe when we switch to the new stuff, we can figure out how to open it up to a broader audience. I don't know.
Yeah.
Maybe at the ONC annual meeting, December 4th and 5th later this year. Maybe we'll be able to kind of have a table there selling some of this equipment for a good charity or something. But yeah, who knows?
Great.
Awesome. All right. Thanks, Stefan. We will talk to you later. We're going to go to a regularly programmed scheduled guest here. Cara, thank you for your patience as we bullshitted and had random people show up and all these things. Hello. Welcome.
I'm crying, laughing back here in the backstage, just like having the best time. I'm like, this is awesome.
Are you applying to be the chief AI officer?
I was thinking about it. If I get one of those t-shirts, like the vintage star t-shirt, I'm like, I'm all in. Like I could totally figure that out. Count me in.
That's pretty cool though. Yeah.
I love it.
Okay, so Cara, just like with Lucienne, I did approximately 2 minutes of research on you and your company before you showed up. Lisa, did you do more than that or did you do zero?
I did 2 minutes of research. I feel great about it.
So like we're into it, this whole bereavement thing, hospice, all the stuff, but you're going to have to give us like, you're going to have to introduce yourself and like what you you're going to have to go for it.
Yeah. I'm like, let's talk about the lightest subject in the world, dying and death. Dun, dun, dun. No, but seriously.
Love it.
No, we need to talk about it because I believe there's a huge gap in the hospitals and in system-wide today of providing grief care when people die. And if you think about like the ICU and ER departments, and then if you think about hospice and palliative care, they have all this wonderful care for the patient. And then when they die, you're literally either handed a piece of paper in some cases, or you're in a tiny windowless room and you're like, your loved one has died. Like, maybe a social worker, maybe a patient experience person will help you out. And it's horrible. It's a pretty bad experience. And I'm speaking firsthand. So I am not in healthcare by background, but when my mom passed away, it was just as I described. We went through many, I'd say, areas of the healthcare system at no time, in a very short amount of time, when she was healthy to passing away in about 90 days. Was anybody like, are you okay? Like, do you need help? Do you need grief care? Like, are you struggling? And we were in the ICU, we were in the oncology center for a short amount of time. And the first time I think somebody asked me was in hospice care. And so, we really on focus enabling hospice care providers to help people, help family members do patient and family-centered grief care. So yeah, that's what we do.
Patient and family-centered grief care. Into it. And I thought you were like an HR person before.
Yeah. So my background, 15 years, primarily within venture-backed startups. I think, when you think about employers, they're the largest payers in the US, like in terms of healthcare. So I've purchased a lot of healthcare. I've purchased a lot of single point solutions. I was actually an HR leader when the pandemic started, and the amount of grief and loss was insane. Like people were resigning at scale, and like the EAPs were failing, and there were no mental health benefits. And I think the other challenge was nobody knows what to do when someone dies either. Like there's like a logistics there that people are struggling with. They're taking, leave to figure out how to plan a funeral. So that was definitely a light bulb moment of like why Betterleave should be in existence. We're an early stage startup and we've been around for maybe 1.5 years now. So yeah, we're figuring out how to provide the best value digital solution and care delivery that we can for hospice groups, employer groups, basically where people are dealing with grief and loss.
So I think about this a lot, like things that like everybody goes through, but no one's prepared for. So like, I kind of felt this way, like having a baby, like the postpartum period, I was like, what the fuck? Like, how does everybody do this? This is dumb. And like, no one prepares you for it. No one talks about it. And like, Lisa and I, like, we're going to document perimenopause and menopause here live on the show. But like, also it sounds like just until recently, like no one has talked about that. and really prepared anyone for it. It seems like similar. Am I like full of shit, or would you agree with that?
No, you're not full of
Happens to
shit.
everyone.
I mean, maybe you are full of shit.
That's
I can qualify that, actually. You might be, but I
She
totally
is also full of shit, but she is right about this for sure.
yeah. I just met you, so I'm not 100% sure on that statement, but I do agree. I just had a baby. He turned 6 months. And you see so many memes on TikTok and Instagram of like, they hand you the baby and they walk you out and they're like, peace, like you got him in strapped in, like you're off. At least I had a binder. When I left the hospital with Charlie, I had a binder of like what to do, what not to do. Like when my mom died, it was like, can I call a funeral home provider? Can I call a funeral provider for you? And that's it. I was like, where's my binder of like what to do and how to do it and like how to manage it?
Super predatory industry, just like all these places, right? New moms, death and dying, right? Lots of predatory industries right there, like waiting to pick you up, right? The funeral home thing. There've been exposés recently about just how terribly trash they are and how hard it is to just be like, I literally just want this person to be cremated like they wanted. That's it. Just need a box. Like, don't need any of the other stuff. Like it's fake or whatever. And so, you know, like there's just all these predatory industries that are ready to pick you up in those situations and no good information. Like I think about this and I feel like now here I am, like, you know, not following my own advice, but who has time for this? Like, what happens? What happens if you get hit by that bus or you get cancer and it's stage 4 and you pass away? Like do you have your like living like trust? Like, do you like what living will? Like, do you know how we could find things? Do you have a password manager that has like a fail safe? Do you know what happens to your Facebook account? Ew. Like all those things they take so much. It's a lot of work. Like it's really hard work to do.
Yeah, and it's fragmented. If you think about what you just said, you mentioned like, okay, an estate plan, a will, you think a financial planner, you think financial tools, and then you have an advanced care plan, and then you think healthcare, the healthcare directive, and you have these fragmented systems that don't work together. But it's like, how can you plan your financial outlook and forecast and not think about your health forecast? Like they're hand in hand. But like a financial advisor is never going to touch your funeral plan. He's never probably going to touch your healthcare directive. But then maybe your PCP is never going to touch your will. So like, why is that so clunky? And like that needs to be solved. Somebody needs to start getting a little bit smarter or feeling a little bit more comfortable and confident to bridge those conversations together so that you can have a comprehensive plan before, you know, a crisis or shit hits.
So interesting. So tell us about your solution. Tell us what you're working on specifically, because I think that was a huge thing. I realized you guys aren't doing all those things, but that's a problem. So what part are you all taking on?
Yeah, so we do many of those things that I mentioned. So the one that we just talked about, the pre-planning, we do that. So within our platform today, you can plan ahead. And that means it could be like you've had a change in health. Like maybe you've been diagnosed with breast cancer and you're like, I'm not going to die tomorrow, but maybe this is my first wake up call. I've had a change in health. I want to get my plan in order. So, and you might also be grieving that change in health. So you can get your plan together in our platform. So that's a big piece of what we do. A huge piece of what we do is grief care, and many different modalities. So like audio, visual, articles, self-help, you name it, but also like we have a pure care delivery mechanism. We have an entire team of grief experts and they're rock stars. Their backgrounds are in grief. Some have worked in hospice, some have worked in hospitals and ERs. They're clinical social workers, or they're licensed marriage family therapists, or they're end-of-life doulas. I mean, we have like a real spectrum of what I would consider like integrated care. Built in the platform, and you can get access to it within a matter of days. And I think the last thing that we do that's really, really valuable is all of that logistics that I mentioned of like, oh my God, what do you do with, like you said, the Facebook account? Like, what do you do with it? We help you. Like, we'll help you figure out like the logistics after loss. So those are the main, I'd say, buckets of what we do.
Nice.
That's pretty awesome. Like, good for you. And this all, first of all, I love entrepreneurs. Everybody knows that. Totally into it. And it's very cool that like you are turning this pretty, you know, not great experience into something that's helping other people. It's freaking awesome. I'm not sure I've ever heard the phrase grief care.
Yeah, it's not common. It's not, in bereavement care is not common. Grief care is not common. I mean, I think like the traditional phrases, I'm trying to think of a traditional phrase. I actually don't know one. Maybe you just have like a mental health. Like I have a mental health issue, or like, I mean, typically when we talk grieving, I mean, grief is actually a major underlying issue to several like depressive episodes or other traumatic events in your life. And we actually help people unlock, like, have you experienced a grief moment, and like, how is that impacting the rest of your life? And it's actually pretty powerful. So there's a lot of education in what we do, because grief care is not a common, I'd say, like, phrase that you hear. But it needs to be there. It needs to be there. It needs to be embedded within oncology centers. It needs to be embedded in ICUs and ERs. It needs to be embedded more in palliative. And it's definitely there in hospice. And I think we're just helping unlock, like, some efficiencies and I'd say beefing up a lot of hospice programs, but it needs to exist more across the spectrum, in my opinion.
Yeah, there's a comment about from Zach again about advanced directives. I think that's one of the areas that connects to our interoperability world. For example, there isn't like a consistent way of doing this. There are some standards, there's some work happening. I think, there also are connections like to, things around medical records that are important as well. Just my own experience, my mom passed away when I was pretty young, when I was 16. This was pre like super widely available electronic medical records, but literally, like, one of the things in that list, right, is like, do you have your relative who passed away, do you have their medical records? What if you need it for something? Like, what if you need it for a claim of some kind, or want to know for the future? Back in the day, right, medical records were destroyed after 7 years, and it still is the case in many situations. Like, all those things are just like out there in the world of medical records and interoperability as well.
I mean, you hit the nail right on the head, like, TMI moment, but like, my mom died from a thyroid cancer. And I was diagnosed with a thyroid deficiency. And I was like,
Wow.
That is so freaky.
You're like,
and
relevant, feels relevant, right? Who knows? Good to know.
I'm like, and I was like, I'll take the medicine. Yes, please. Like, I don't care if I take this medicine for the rest of my life. Like, I don't want to wake up at 60 and die from an undiagnosed thyroid cancer. Like, but like, if I hadn't known that, or if I, to your point, like, that knowledge is power, and like, having that data and understanding what was like wrong, I think is super powerful for sure.
Well, and the way that it's picked up for me is like, everyone depends on you on filling out the same information when you go to the doctor 100 trillion times in the same stupid clipboard, because they still can't manage to somehow connect that information, even though I fill it out every single year about 10 times minimum. Obviously, because I filled it out clearly and knew the answers, like, I'm able to move into screening protocols and things like that, right? Years ago now, I was tested for BRCA negative. Don't worry, everyone. And so, but that kind of thing is like relevant. Like, it should have been on me to remember, like, oh, my mom passed away from breast cancer, so I should do this, right? There's no reason why this information couldn't have flown or shouldn't flow in the future when it's relevant to your relative, to your blood relative.
Totally agree. And I don't know if you felt the same way, Lisa, but when you fill it out and they see like your mom died, that like the weirdness that comes
again
with
and again.
They're like, it's like, oh, sorry about that. And they're like, they don't know if they should ask or dig in or not. And you're just like, yeah, I mean, you should definitely know. And this is how it relates to me. And like, but it's like, there's an awkwardness for sure. I don't know if you feel the same way. It's like, we need to
it's a long time ago, and it's not relevant, but every day you have to fill it out again. Every time you go to the doctor and you're like, okay, here we go again. So many things we could improve.
Yeah, let's do it. We're on a mission. So we're going to try. We'll try to take like a tiny piece, a whack at it, and hopefully make it.
Nice. And it sounds like you said hospice organizations are your clients. I assume commercial plans and employer plans or self-insured employers. And then what about the government payers, Medicaid and Medicare? Are they picking it up?
Yeah. So we're pending approval. So we've submitted our contracts and our applications to be credentialed. So cool. hopefully soon. I mean, hi CMS, if you get my application, please approve this year and not next year. Like,
we have at least one fan from CMS, like probably. So
yeah, perfect. Yeah,
they definitely heard it. So I'm sure they'll get an email soon.
Hear me. No, I think accessibility is really important, especially to mental health access. And when you think about grief care, like it's even a smaller niche of people that are credentialed and licensed to be grief experts. And so we do take insurance and we do work with payers. I think it's really important. I know a lot of groups out there don't. It takes a long time and it's a pain in the ass, but like it's totally worth it. If you can do it, it unlocks people's ability to get the care that they need, in my opinion. So we do work with them. We work with hospice groups. We work with palliative care groups. We work with hospitals, also inpatient, home care. So yeah, basically anywhere that if you're an organization that it has patient and family members that potentially are going through grief and loss, like we can help.
Awesome. Awesome. All right. Give us one big thing for our readers. Yeah.
Our readers.
Our loyal fans
readers.
to think about over the weekend related to grief care. And well, actually you can do whatever you want.
I was like, I mean, I guess my biggest thing is like, do you have a plan? You should get one. It doesn't matter. There doesn't have to be a reason. If you just hear this, like, do it, get it done, draft one.
Get a plan.
Do it. Doesn't matter. It can be it can be an advanced care plan, healthcare director. It doesn't matter. Just do it. Just like get it done. Don't think about it again. That's my, you can do it. Like, let's go. Let's go. So
Nice.
yeah. There you go.
Make a plan.
Make a plan.
Make a plan. Mostly stick to the plan.
You probably never thought about it and you'll never think about it again. So do it this weekend.
That's right.
Do it this
Awesome.
weekend. Loyal fans, do your advanced directives, do all of your planning for catastrophes and just in general life this weekend, please. Thank you.
That's
Thank
right.
you, America. All right.
Awesome.
Okay. Cara, thank you so much for joining us.
Thank
You're the
you.
best. Appreciate it. Thank you for dealing with all of our random guests who show up
Nonsense.
sometimes. Yeah, Lisa, what else? What else?
We
What
did
else? I don't know. We did it. We made it through another episode and we mostly went live. So like Melissa's
Have a
clapping
great
for us. She's
weekend.
ready.
So proud of you guys. We did so good today.
Yeah.
Amazing.
We did good today. We did well. Okay. Thanks, America. And
Bye,
apply to those
everyone.
jobs. You only have 2 weeks. May the best person win. Love it.
Yep.